Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and this is going to be our GI lecture for Med-Surg or adult health classes. This lecture is going to cover a little bit more than half, maybe two-thirds of what you would learn in nursing school when it comes to GI. This video is meant to be used as getting ready for that class, so you walk in day one knowing most of the material. This video can also be used as a really good NCLEX review. So we're going to start with anatomy and physiology review, and we're going to work our way up towards the last part of the video, which is where going to be where we go through each and every disease. So we start with the A&P review. Now, as we go through each of the parts of the GI system, I do have a highlighted section, and then I do have a non-highlighted section. I'm just going to cover and lecture the highlighted section. The rest of it is just there. If you want to make flashcards or if you feel that this is more helpful to you to see under each part of the anatomy physiology, such as the esophagus or the liver or the stomach, which diseases are associated with that or with that exact part of the GI system. I did break it down for you, but to keep this lecture brief, we're going to go through it, just the highlighted section of this first part. So we start, the GI system begins with the mouth. It's the oral cavity, and that starts the digestive process. It's responsible for two things, mechanical and chemical digestion. What does that mean? Mechanical is the physical crushing, the physical breaking down of what we eat, and the chemical digestion is where the enzymes in our saliva start to actually chemically break down the food that we eat. From the mouth, it moves down to our esophagus. The esophagus is a muscular tube that carries food and liquid, everything that comes into our mouth, down into our stomach. The esophagus moves with what's called peristalsis. Peristalsis is defined as rhythmic contractions. What does that mean? Rhythmic contraction is where I squeeze, 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 like you would do with toothpaste in order to get it out of the tube. That's how things move through the esophagus, as well as most of our GI system. Next, we have the stomach. From the esophagus goes down to the stomach. The stomach stores, mixes, and digests food and liquids that we eat, and it uses gastric acids and enzymes to facilitate this process. Next, we have the small intestine. The small intestine is many feet long. The small intestine is responsible for the majority of nutrient absorption and digestion. And you should know that it's divided into three sections. The very first part of it is called the duodenum. That's the first part that goes from the stomach into the small intestine, and it goes into the duodenum. From there, it goes to the jejunum, and from there, it goes to the ileum. After the small intestine, it goes to the large intestine. Large intestine is significantly shorter. The large intestine is responsible for water and electrolyte absorption, also the small intestine in as well, but the large intestine is mostly responsible for forming and storing feces until we have a bowel movement. The cecum is just one part of the anatomy that you should know. If you see that term, that is the first part of the large intestine. The large intestine ends at the rectum or the anus. The anus is the end of the digestive system. So it started at the mouth with everything we ate, worked its way through the esophagus, the stomach, small intestine, large intestine, and ends at the anus. The anus is responsible for facilitating and controlling our bowel movements. Now we're going to go through a few different organs that do fall under GI. First, we're going to have the liver. The liver has a bunch of different roles, and we deal with this all the time. You may have heard the term hepatotoxic in terms of drugs or different chemicals that are hepatotoxic. That means toxic to the liver, to the hepatocytes, which is the cells of the liver. So the liver is responsible for detoxifying harmful substances. It's responsible for producing bile for fat digestion. It's responsible for metabolizing nutrients and synthesizing proteins. In addition to all of those things that it does, it also stores blood, vitamins, and minerals. There's a lot of issues that can come from the liver, and we're going to discuss that in depth coming up. Next, we have the pancreas. Again, just a quick A&P review. The pancreas is both an endocrine gland and an exocrine gland. What does that mean? That means it works partially, part of its functions are part of the endocrine, the hormonal system, and that's the things such as insulin and glucagon. And then it also has exocrine or digestive functions where it works as part of the GI system, involved in nutrients and our digestion, such as through the production of and usage of amylase, lipase, and trypsin. Next, we have the gallbladder. The gallbladder stores and concentrates bile. Bile is then released into the small intestine, where it's a key part in the digestion and absorption of fats. And you can notice when a patient has gallbladder issues, they're going to have an issue eating fatty foods. Now let's go on to GI assessment and diagnostics. Start with basic assessment. We have the physical exam. When we talk about a physical exam of the abdomen, right now we're going to focus on the abdomen itself. First thing to do is you're going to expose the patient's abdomen and do it with privacy in mind. And then we go through 4 steps. First, we inspect, which is where we visually look. Before we touch anything, we visually look. Next, we auscultate, which is where we listen. Then we percuss if you're going to be doing that, and then we palpate if you're going to be doing that. It's very important that you do it in this order, and that's a common test question, because once we palpate, once we start pushing around on a patient's abdomen, it can actually change the inspection or the auscultation. So we want to do it in this exact order. First look, then listen, then you start touching with percussing and then palpating. When we're listening to bowel sounds, and again, you probably learned this in the skills lab, but when we're listening to bowel sounds, we listen to 4 quadrants: right upper, right lower, left upper, left lower. And we also, and I didn't mean that in any particular order, I was just listing off the 4 quads. And we're going to do it 1 quad at a time. We listen for a few seconds or until we hear the bowel sounds. Once we hear the bowel sounds, we determine if they're normal, hypoactive, hyperactive. And that does take some getting used to, especially as a new nurse or a nursing student, of what's hypoactive, hyperactive, and normal. Finally, if we don't hear anything as we're listening, we wait a full 5 minutes. If in 5 minutes we don't hear anything, then we can say that the patient is absent bowel sounds in that quadrant or possibly everywhere, because that is a really big deal if a patient has no bowel sounds, and we're going to learn more about that coming up. Now we move on to imaging for the GI system. We're going to start with an upper GI endoscopy. Often in your textbook, you'll see this listed as an EGD. I'm not going to try to pronounce the actual full word because I'm probably going to butcher it. But let's go ahead and talk a little bit about it. This is used to diagnose conditions such as GERD, peptic ulcers, esophagitis, and upper GI bleeding. So it goes down in through the mouth, and it goes through, it can check the esophagus, it can also get the stomach. Patients must be NPO prior to this procedure. It's a very common procedure. The patients do get partially sedated for this, but we do use this all the time diagnostically. Next, we have a colonoscopy. This is the gold standard for detecting colorectal polyps, cancer, inflammatory bowel disease, and diverticulosis. It is important to note that, again, patients, this is a surgical procedure. This is going to be full anesthesia and all of that, so you have to be aware of that. Next, and this is the one that gets a colon cleansing beforehand, where the patient has to be NPO, clear liquid diet, and be using something like a barium enema. Next, we have the abdominal X-ray, which is sometimes referred to as a KUB. An abdominal X-ray is used to look via regular simple plain film X-ray, and it's used for detecting bowel obstructions, perforations, or foreign bodies. KUB stands for kidneys, ureter, and bladder, because that's the most useful part that we get out of an abdominal X-ray. Next, we have a CT scan or a CAT scan of the abdomen and pelvis. Those two terms mean the same thing. We use this very often. We use this for appendicitis, diverticulitis, pancreatitis, masses. We also use this sometimes to rule out if the patient's having severe abdominal pain and we don't know what it is and we don't have a suspicion, then we could just do a CAT scan of the abdomen and pelvis and see what we find. Next, we have ultrasound. Ultrasound is generally more preferred to CT scan, CAT scan, for the simple reason being that it doesn't have any radiation. We know that every time a patient gets a dose of radiation, even though generally this is very, very safe, we use very small amounts, and in the vast majority of patients, this will never be an issue, but we do still prefer to avoid that, which ultrasound does. Ultrasound uses sound waves. So we do use this when it's appropriate, and it's appropriate to check for gallstones, biliary obstruction, ascites. There are a few other things that's beyond this lecture, but there are a few other times we would also prefer ultrasound. Again, if two things being equal, ultrasound and CAT scan, we prefer an ultrasound. Next, we have some labs. So the last part of this is going to be labs. So we have the LFTs, liver function test. This is going to check your AST, your ALT, your bilirubin, your alkaline phosphatase, your ammonia, and your albumin. All of these are liver labs. So if you see any of these on a test as which one will be appropriate for assessing the liver, all of these would be correct answers. Next, we have our pancreas labs, which are amylase and lipase, and these are used to diagnose acute and chronic pancreatitis, and we can use it to determine, based on the elevation of each of these and the ratio of elevation, which is probably beyond our N level, but it can actually tell us whether it's acute versus chronic pancreatitis. The next lab we have is a FOBT, a fecal occult blood test. And this test is where we take this little card and we open it up. We smear a drop of the patient's stool on the card, and then the card will determine whether or not there's any microscopic, meaning not visual to the naked eye, any blood in the stool. And that can tell us if the patient has any sort of a GI bleed. And it can also be used to rule out the patient having a GI bleed. Excuse me. The next lab we have are stool cultures. And these are used to assess infections. Again, you should be familiar with cultures by now in nursing school, because we use cultures for everything, for sputum cultures, blood cultures, urine cultures, but we also have stool cultures. And finally, we have H. pylori testing. We do have 3 different tests that we can use for H. pylori. The most common is what's called a urea breath test, which is where we actually use a breath sample. The patient breathes into a machine, and that's our test for H. pylori. That's the most common one, but we do have other stool tests and blood tests as well. Now let's go through 3 quick sections as far as technical skills of GI. Most of this would be covered in a skills exam, but I did include it in this GI section to make it universal for all nursing schools. Next, so let's talk about NG and OG tubes. NG tubes, a nasogastric tube, it goes in through the nose, down into the stomach, into the gastric, and where it goes orogastric, down the throat, down into the stomach. Both of these are used for patients that we want to get access to the stomach, but that they are not able to safely swallow or eat for whatever reason, or sometimes we do it for decompression. So let's go through it. The indications for these tubes is decompression, where we want to get, let's say, a lot of air or volume out of the stomach. We do it for feedings where the patient's NPO are unable, or not NPO, but where they're unable to swallow, or NPO due to not being able to swallow. I want to clarify this point so I don't confuse myself or you. NPO means nothing per oral, meaning they can't eat or drink anything. However, NPO can be because the patient's unconscious and they're not physically able to swallow. It could be because they failed a swallow study, which means that the patient is unable to safely swallow without the contents of what they're swallowing ending up in the lungs. Remember, at the back of our throat, we have two pipes. One goes to the lungs, one goes to the stomach. In a perfect person, or I should say in a healthy upper airway person, we're going to have that everything they swallow goes down into the GI system. However, in someone that has what's called failed to swallow study, where they're not able to safely swallow, in that patient, some of what they swallow, or even all of it, ends up in the lungs, which is a massive issue because then it can end up with aspiration or aspiration pneumonia. So for that reason, we very often place patients NPO, especially after a stroke or things like that. And we're going to talk about this again in the last few minutes of this lecture, but we make them NPO. So again, when we have a patient who's NPO because they're unable to swallow study, but we still, because they failed to swallow study, but we still want to give them feedings, we could put a tube in. We could also use it for medication administration and a few other things. To confirm placement, it is universally required after an NG or OG tube is placed, the patient must get a chest x-ray or chest x-ray that includes the stomach in order to see that the tube is in the correct place. Because if you put the tube down and it went into the lungs, a lot of good that did. So we have to absolutely make sure you can never use a tube until it has been confirmed by x-ray. Plus, additionally, every time we use a tube, we're always going to confirm it prior to using it. There are two other less reliable and less commonly used methods to determine placing, which is pH testing or auscultation. Because these are not in all cases, the patient has already had a chest x-ray confirming it, then we can go ahead and use this as just our routine follow-up testing. Every time we use it, we can use, let's say, the auscultation method to confirm that it's still good to use it right now. Before you use it and after you use it, you're always going to flush it with sterile water. And you can also do that as you're testing to make sure that it's in the correct place. Because of the risk of aspiration, all patients that have an NG or OG tube always need to have the head of bed elevated. It can never be flat, and they should stay that way for at least 30 to 60 minutes after feeding. You cannot place an NG or OG tube if there's trauma up here or if there's an issue with the esophagus, such as esophageal varices or recent esophageal surgery or bleeding. If a patient has nasal fractures or jaw fractures or anything that can mess up the anatomy, the risks of putting it in correctly go way up, and for that reason, we don't do it. Or in those cases, the provider themselves would be the one to put it in. Next, we have our G tube or our J tube. The indications when we use these is for more long-term enteral nutrition. So an NG, OG tube would be for a few days, a G tube, or maybe up to a week or two possibly, but a G tube, J tube is talking where we're going to be doing this for many, many weeks or months on end, or permanently. So in those cases, we put a G tube or J tube. What is that? A G tube or a gastric tube is where we put the tube directly. It's a surgical procedure. We make a hole in the abdomen and put the tube right into the stomach. That's a G tube, or into the jejunum. That's a J tube. When we're using these tubes, if you're giving a patient feeding, and these tubes are always being used for feedings, when we have we wouldn't place this in for other reasons other than the patient needs this for their nutrition. When a patient does have one of these tubes in, if it's a G tube, those patients can get bolus feedings, meaning where we take the big syringe, connect it, and give them a whole meal at once, or continuous feeding where it's on a pump. A J tube can only be used with continuous feeding because you can't just give it a whole big bolus like the stomach can. Just like when we eat, the stomach can tolerate if we eat a whole big meal at once. If we didn't have the stomach, it would just be one little bit at a time if it was going straight into the jejunum. When you're using this, again, also flush with sterile water before and after feedings. Again, with a G tube, especially make sure the head of bed is elevated during feedings and after feedings. J tubes don't have that as much of a risk of it actually coming back up or them aspirating. Again, aspirating is where the contents that were meant for the GI system end up in the lungs. There's not that much of an issue with the J tube because we're talking that it would have to go back to the stomach, back to the esophagus, back up to the oral cavity, and then go the wrong way into the lungs. So it's not as much of a risk. Complications with either of these tubes are infection, the tube coming out, the tube getting clogged, or physical issues with the site of the stoma, which is the hole where the tube is placed. Finally, we have a colostomy. Colostomy is a surgical stoma. Again, a stoma means a hole. It's a surgical surgical hole that's made in the colon, and it's meant to divert stool instead of the patient having to get the stool gone by going through the rectum to anus, if the patient is able to get the stool out, it goes directly into this bag, into the colostomy. When you're taking care of a colostomy, it's a very complex nursing whole discussion about it. I'm going to go through the 2-second version. When you're doing it, always assess the site before you're doing anything with it. Assess for the color of the skin. Is it pink? Is it moist? Avoid irritating it, and make sure you keep it dry. And make sure you're using a proper ostomy appliance. If you are the one educating a patient for colostomy care, again, that's way beyond what I'm going to get into this lecture, but just the basics, make sure you teach them when to empty it, when it's a third to a half full, depending on which textbook I was reviewing, or let them know how often to change the actual bag itself. That's generally every 3 to 5 days is the recommendation. Again, that's to reduce the risk of infection. Also keep in mind these patients, they definitely need support in terms of body image concerns and other areas related to the situation that they're in. So please make sure they get that support or refer them if needed. Now we get into actually talking about all the different diseases, and we're going to spend most of the rest of the lecture on that. So let's first start with one quick note that I didn't have anywhere else to put in this lecture. There are 3 non-pharmacological interventions that we have for constipation and diarrhea, and you can see it over and over again when we get to the diseases as we're about to. So I want to cover it real quick. Fiber, fluids, and activity. The more activity a patient has, the more fiber they take in and the more fluids they drink, the less likely they are to be constipated. But on the flip side, those could also cause diarrhea. Not likely, but they could also cause that. So if anything causes constipation, a non-pharmacological intervention would be to increase fluids, increase fiber, increase activity. You're going to see that on a lot of your tests, so make sure you know that. Now let's start getting into the diseases, and this can be the rest of our lecture. So we're going to start with GERD, and for each disease, we're going to go through the patho, we're going to go through what are the signs and symptoms, the presentation, we're going to go through how it's diagnosed, and we're going to go through what you're going to do to treat it. So the pathophysiology of GERD. GERD is gastroesophageal reflux disease, and it occurs most commonly due to the LES, the lower esophageal sphincter. This is a one-way sphincter that sits at the bottom of our esophagus, between our esophagus and our stomach, and it makes sure that everything that comes down doesn't come back up. Obviously, it does with vomiting, but that's an appropriate function of the LES to allow that. But on a regular basis, it should be one way, one direction, esophagus to stomach. If it fails and stuff from the stomach can come back up into the esophagus, we end up with a problem. What's the problem? The problem is the stomach has gastric juices that are there to help with digestion. And those gastric juices are extremely acidic. They're extremely toxic to the whole rest of the body. The stomach can tolerate it because the stomach has a special protective lining, but the rest of the body does not. So if those gastric juices or that chocolate cake that you ate that now got soaked in that gastric juice, if the lower esophageal sphincter fails and that food is able to come back up into the esophagus, it's now coated with or soaked in those gastric juices, that really toxic acidic fluid. And now that that's exposed to the esophagus tissue, which doesn't have that protective stomach lining, it is really harmful, really painful, really uncomfortable. That's what GERD is. And eventually that can cause damage to the actual esophagus. This presents with heartburn. It presents with epigastric pain. It can also be a cough. It's one of the top 10 causes of cough, and it can cause some hoarseness. This is diagnosed based on presentation where the patient says they explain the heartburn, they explain when they get it, all of those type of things. It's a very classic case. Millions of people have GERD. Fortunately, it's easily treatable. So how do we treat it? First of all, we avoid trigger foods. Most patients have the foods that make it worse for them, and we educate them on figuring out what those are and avoiding them. Next, we also teach patients not to eat before bedtime, mainly for the reason being that when we go to bed, we lay flat, which means that if the sphincter is not doing a good job, then hopefully when we're at least standing or sitting, gravity can keep the food from coming from the stomach back up into the esophagus. When we lay flat, that's a problem. So we definitely want to recommend the patient not eat 2 to 3 hours before bedtime, because we want that food out of the stomach before they lie flat so that it doesn't come back up into the esophagus. Also, we could tell them to eat small meals. Again, if the stomach's not as full, less chance of it coming back up into the esophagus. Some of the common triggers I did list here. This is a common nursing test question. Peppermint, chocolate, coffee, caffeine, fried foods, carbonation, and alcohol are all known triggers for GERD, but again, every patient has their own. You can also educate patients to reduce weight and to exercise. Both of those are known to help with GERD. And GERD, if left uncontrolled, if we don't teach them to avoid it, if they're just dealing with it all the time, or let's say they're popping Tums to fix it or things like that, then that can lead to Barrett's esophagus as well as cancer. Next, we have peptic ulcer disease. Peptic ulcer disease is a very similar problem because it's also a problem with that really acidic gastric fluid. But this time, instead of the problem being in the esophagus, the problem's in the stomach or the duodenum. And what are we talking here? So we just said that the stomach has this really gastric, really acidic juice, fluid, and this fluid can be harmful, can be damaging, can literally burrow through and make holes in the live tissues that we all have inside of us. The stomach can tolerate it because it has this protective lining. The problem becomes when that protective lining disintegrates. If that protective lining goes away, now this acid is no longer contained. Now it's exposed to the underlying tissue, and now it can start to dig a hole and burn its way through because it's so toxic. And that's where a patient gets ulcer. An ulcer is literally a hole. A gastric ulcer is a hole in the stomach. Duodenal ulcer is a hole in the duodenum. Esophageal is a hole in the esophagus. And this is caused by that gastric fluid. The most common cause of what allows this to happen, what allows that stomach lining to break down, are NSAIDs. Because if you already learned pharmacology, you know that NSAIDs block the production of that stomach lining. H. pylori, which is a bacterial pathogen, it can also break down the stomach lining. And stress can do a variety of things that can make a patient at risk of developing an ulcer. The presentation of this is going to be epigastric pain. Sometimes it's better with eating for duodenal ulcer. Sometimes it's worse with eating for a gastric ulcer. It can also cause nausea if it's getting really bad to the point that the gastric acid has burrowed its way and dug a hole all the way through tissue into blood vessels. We can end up with melena, which is blood in the stool, or hematemesis, which is blood in vomit. The diagnosis of this is done based on history. Let's say they say they use NSAIDs 800 milligrams 3 times a day for the last 10 years. That's a pretty big red flag. It can be diagnosed with an upper endoscopy, which is the EGD, or H. pylori testing if that's what we suspect caused it. Any patient who's diagnosed with PUD is generally going to be tested for H. pylori so that we can rule that out, because if it is H. pylori, then the treatment is going to include antibiotics because that's a bacterial pathogen. If it's not H. pylori, if it's NSAID use, which is more common, then we would go ahead and we would treat them with a PPI or an H2RA. A PPI is a proton pump inhibitor, such as omeprazole or pantoprazole. Those are over-the-counter medications known as Prilosec or Protonix, or an H2RA that's a little bit less powerful of a drug, and that's going to be famotidine. Over-the-counter is Pepcid. We're also going to make sure to prevent this for the future, so we're going to discontinue any NSAIDs that they're on. There is one medication you'll learn about in pharmacology that can actually be used with NSAIDs to help protect the patient from the NSAIDs, but we're not going to get into that in this lecture. And then also, we're going to recommend the patient eat smaller meals, quit smoking if that's applicable. And obviously, as a nurse, we're going to monitor for any signs that this is turning into a GI bleed. Next, we have gastritis. Gastritis is an inflammation of the actual stomach lining of the mucosa, the gastric mucosa. This can be acute or chronic. If it's acute, it's most commonly caused by NSAIDs or alcohol or specific foods, or if it's chronic, it's usually caused by H. pylori. This is going to present with abdominal pain. The patient's going to be anorexic, meaning they have no appetite, and nausea, vomiting, and heartburn. This is diagnosed based on the presentation, and then we may follow it up with an EGD, an upper endoscopy. How do we treat this? Very similar. You're going to see this very commonly throughout the rest of this lecture. We're going to address the underlying causes, the triggers that trigger it in this patient. We're going to monitor the patient to develop a GI bleed. That would be a huge nursing fail if we didn't catch the signs of the GI bleed. Let's say the heart rate suddenly heading up, or blood pressure heading down, or anything like that. And finally, if it is caused by H. pylori, meaning it's the chronic one, then we would definitely treat them with antibiotics. Next, we have a hiatal hernia. I don't know if this would really be part of your GI lecture, but it was in some of the textbooks I looked at, so I am throwing it in here. I'll go through it quickly. The pathophysiology, unlike most hernias you may be familiar with, you're not going to see a bulge outside of the stomach. A hiatal hernia is where the stomach protrudes up through the diaphragm into the thoracic cavity that holds our heart and lungs. So it's not an external hernia, it's a hiatal hernia where it goes up from the abdominal region up into the thoracic region. The presentation is going to be heartburn, vomiting, and regurgitation. This is diagnosed by a CAT scan would find this very quickly. And finally, management of this would be smaller meals. We would tell the patient to avoid lying flat after meals, because again, if this is the stomach coming up into the thoracic cavity, the stomach is bigger after meals, or it's enlarged or engorged, whatever we want to call it. So we want to avoid them laying flat. Again, that's a really good nursing question. Make sure you remember that. And finally, surgical referral for definitive treatment. Next, we have cholecystitis. Cystitis means inflammation. So cholecystitis, chole is the gallbladder. So this can be inflammation of the gallbladder. It could be an acute, which would usually be related to cholelithiasis, which is a gallstone, or it could be chronic, and that could be a number of different issues, such as a bile emptying issue. When a patient presents with this, they're going to have the right upper quadrant pain. That's classic for the liver or the gallbladder. It's going to be worse after a high-fat meal, because remember we said at the very beginning of this lecture in anatomy, we said that the gallbladder is responsible for bile. Bile is responsible for breaking down fat digestion. Without it, the patient is not able to break down the proper fat meal. So a high fat meal is going to be very symptomatic if they're having a gallbladder issue. It can also present with nausea and vomiting, indigestion, and Murphy sign. The patient may have biliary obstruction, and that would then have all the all the liver issues such as jaundice. Next, we have that this is diagnosed based on an ultrasound. Again, I said we prefer an ultrasound where possible. And the treatment for this, we're going to have the patient eat small, low-fat meals. They're going to avoid flatulence triggers, anything that makes them gassy. We're going to give them antibiotics if they have cholecystitis. If it's an infectious cause, then we're going to give them antibiotics as well. And they may need surgical referral for a gallbladder removal, which is called cholecystectomy. Cholelithiasis, just real quick, are gallstones. Gallstones are often asymptomatic, but they can cause gallbladder issues like we just mentioned. Next, we have liver cirrhosis, and then we're going to be done with the liver. So, actually, no, we're not. But liver cirrhosis is the end of where we get when we have liver diseases. So what's the pathophysiology here? Well, it's a chronic progressive liver disease that results in destroyed liver cells, the hepatocytes. It can come from a lot of different things. It can come from hepatitis. It can come from alcohol use disorder, so chronic alcoholism is what we used to call that. It can come from NAFLD or NASH. We're going to talk about both of those in just a few minutes. The presentation of this is most commonly asymptomatic. This is something that patients may get told when they get their annual physical and we get their labs back and we see their AST, ALT or something like that. The complications of this include portal hypertension, which is high blood pressure through the blood vessels of the liver, ascites, which is a buildup of fluid, coagulopathy, which is clotting problems, hepatic encephalopathy, which is swelling on the brain due to elevated ammonia levels, which we'll talk about in a bit, and esophageal varices, which is swollen veins, blood vessels along the esophagus. Again, we'll talk about that in a little bit. Liver cirrhosis is diagnosed based on labs such as the AST, ALT, and bilirubin, as well as the history, imaging, and a biopsy. The management for this is to figure out what caused it. If it's the hepatitis, let's fix that. If it's NAFLD, there's not much we can do for that, but let's try to fix that. We're going to try to fix the underlying problem. Liver cirrhosis can lead to hepatorenal syndrome. Hepatorenal syndrome is where the kidneys start to fail because the liver is failing. It can also cause hepatic encephalopathy, and it could cause cancer. Real quick, hepatic encephalopathy, because I've definitely seen this on some nursing GI test banks. Hepatic encephalopathy is where a patient has a high ammonia level because the liver is not functioning well, and it can cause the patient to have altered mental status. Encephalopathy, again, is swelling of the brain, so it can cause altered mental status and other neurological issues, including the patient being in a coma. And this is treated with lactulose or other ways to control that ammonia level. Next, we have esophageal varices. Esophageal varices, the pathophysiology is it's dilated veins in the esophagus due to portal hypertension. Portal hypertension, you should remember, is high blood pressure in the veins or the blood vessels of the liver. And this excessive pressure, this hypertension, is going to cause a dilation of the veins in the esophagus. Now that those veins are dilated, they're at risk of rupture because the walls have become thinner. The presentation for this is almost always asymptomatic. When do we notice it? When they rupture. When they rupture, this can be life-threatening bleeding. It can be vomiting of blood. It can be melena, which is blood in the stool if they've been swallowing that blood, or it's just heading down. And finally, it can eventually cause hypovolemic shock and death if the patient bleeds out enough. This is diagnosed based on an upper endoscopy. We'll manage this first by stabilizing the patient. Again, most of the time we don't catch this until it's ruptured, or we're not treating it, I should say, until it's actually ruptured. And we could prophylactically treat it if we are aware of it and we know that it's getting really bad. We can do a surgical ligation in order to correct it. Now we're going to move on to hepatitis. There's going to be a lot of test questions in GI nursing about hepatitis. Let's go through it. Hepatitis is exactly the sound. Hepa is the liver cells. Itis is inflammation, so inflammation of the liver cells. It can be caused by infection or other things. Let's go through the 5 types, A, B, C, D, E. A is always fecal oral transmission, and A is curable. You're going to notice A and C are curable. B, D, and E you have forever. So A and C are the curable ones. A is the fecal oral route. E is the fecal oral route. B, C, and D are blood-borne transmission. B is the one that most of you in nursing school are probably very familiar with because you probably had to get tested or vaccinated or titers for hepatitis B. That one is transmitted by blood-borne, by sexual, and by perinatal, meaning mom to baby. And that one is treatable but not curable. Hepatitis C, blood-borne transmission, curable, and D and E are both treatable but not curable. So all of these are treatable, but 2 of them, A and C, we can actually get rid of it for you. B, D, and E you're stuck with for life. The presentation is going to be all the liver signs and symptoms. So fatigue, you're going to have malaise, not feeling well. You can have nausea, vomiting, you can have anorexia. You can have jaundice where the skin or the pupils start to turn a yellowish tinge. You can have right upper quadrant pain. Again, that's where the liver is. You're going to have fever if this gets bad, and you may even have full-blown liver complications, and this can lead to liver cirrhosis and liver failure. The diagnosis of these, I threw these in here. I'm not going to go through it. It's all the different tests that we have for diagnosing hepatitis A, B, C, D, E. They each have different tests. They each have tests, whether it's for acute or chronic. I've seen this in one or two nursing textbooks, but really you're not going to get tested on this, certainly not on the NCLEX, to know which test shows immunity versus exposure versus active versus chronic, all of that. I did throw it on here in case your school wants to cover it, but I'm not going to go through it in detail. I can tell you if you go on to the NP or MD level, then you absolutely will have to know which test tells you what. The management for hepatitis, we're going to give them supportive care, meaning manage their symptoms. We're also going to give them antiviral treatment. We'll give it acutely for most of these. And if they have hepatitis B virus, which is not curable, it's treatable, that they're going to get it long term. We're also going to tell them to avoid alcohol and avoid getting others infected. We're also going to tell them to avoid anything that can be toxic to the liver, such as hepatotoxic medications. Next, we have NAFLD or NASH, and it's also known as MASLD, MASH. So let's break this all down. NAFLD stands for non-alcoholic fatty liver disease. This is where the patient has liver disease, but it's not because of alcoholism, which up until recently was the most common cause. So we have a disease, it's called non-alcoholic fatty liver disease. It's now becoming more, in the newer textbooks that I've reviewed, it's now called MASLD, metabolic associated steatotic liver disease. And that's a newer name for NAFLD. Most of your textbooks probably still use NAFLD. That's what I'm used to. That's what I'm going to use in this lecture. NAFLD can progress to NASH. NASH, N-A-S-H, is again non-alcoholic steatotic hepatitis. So that means it's not due to alcohol. Steatotic is fatty. Hepatitis is inflammation of the cells. So that's going to be NASH, and that's a progression from NAFLD. MASH is, instead of non-alcoholic, it's metabolic associated. So that's really the only difference between NAF and the MAS and the NA and the MA. Anyways, hopefully I didn't confuse you there. NAFLD is what I'm going to talk about really for right now. NAFLD is a fat buildup, steatosis, without significant alcohol consumption. This is generally diagnosed with pre-existing metabolic disorder. And very often, if you go to your provider and they do your annual labs and you come up and you have, let's say, a little bit, your cholesterol is a little borderline, and your sugar is a little borderline, they may tell you that your AST and your ALT are a little bit elevated, and they may tell you that that is likely due to NAFLD, fatty liver disease. And what do you do for it? The same thing you should be doing for your cholesterol and for the diabetes, eating healthier and exercising. That is the treatment for this. NASH, or non-alcoholic steatotic hepatitis, is going to be a progressive form of NAFLD. Remember, this hepatitis is different than the one above because that one is an infectious process. This one is not. It's simply a different inflammation of the hepatocytes. NASH is a progressive form of NAFLD, where steatosis is accompanied by inflammation and hepatocellular injury, and this can lead to cirrhosis. It used to be that everyone who had liver cirrhosis, it was almost always from alcohol issues. Now it's becoming alcohol and bad diet, which is where NAFLD and NASH comes in. How does it present? It's pretty much asymptomatic. You're not going to know it unless you go for labs or start to end up with really bad liver issues, at which point it's not going to be NAFLD, it's going to be cirrhosis or something like that. It's diagnosed based on AST, and ultrasound. I will tell you, in the pharmacology world, we are coming up with medications to treat NASH, but for right now, it's certainly not going to be in your nursing textbooks, definitely not on the NCLEX. The management for this is TLCs, which stands for therapeutic life changes. The cardiac video that is still forthcoming is going to talk extensively about therapeutic lifestyle changes. This is the more exercise, aerobic exercise. This is the better diet, et cetera, et cetera. Also manage any comorbidities, because almost always NAFLD is going to be together with high blood pressure, cholesterol, diabetes, all the stuff that's so common in the United States. And finally, we're going to monitor this on a routine basis every year or every 6 months, depending how bad it is, because at some point, if it's not managed, it will turn into cirrhosis. Next, we have pancreatitis. Pancreatitis, the pathophysiology is acute or chronic inflammation of the pancreas. This can be caused by alcohol, that's the most common, or trauma infection, and there are a few other more rare examples of when that is caused. Presentation of this is going to be severe persistent upper gastric pain, or I'm sorry, epigastric pain that radiates to the back, and it's worse when we're lying down. There are two things you definitely need to know for nursing school exams, which are Gray Turner sign and Cullen sign. Gray Turner's is where you have flank ecchymosis. That's going to be hematoma, black and blue mark basically on the sides. Or Cullen sign is going to be that hematoma, that black and blue, that sign of bleeding under the skin in the periumbilical, which is around the umbilicus, around the belly button. Also, nausea, vomiting, and anorexia are all classic signs and symptoms of pancreatitis. This is diagnosed based on presentation, based on history. A lot of the time, these patients have a history of repeat pancreatitis, and also by elevated amylase and lipase. That tells us right away if they have pancreatitis. Plus, we would always get a CT scan, or almost always, to confirm the diagnosis and see how bad it is. Management is going to be NPO. Absolutely, these patients should not be eating. They are going to be getting a ton of IV fluids. They're going to be getting a lot of pain management because it's a very painful condition. They're going to get H2RAs. That's that histamine 2 receptor antagonist that protects the stomach from other issues. They're also going to get a monitor for their calcium levels. And if it's caused by alcohol, which it almost always is, we're going to educate, not almost always, but the majority of the time, we're going to educate them on avoiding this for the future. Next, we move on to IBS, irritable bowel syndrome. Don't confuse this with IBD, inflammatory bowel disease. That's coming up very next. Pathophysiology of IBS is it's a functional GI disorder. It's in layman's terms, it's hyperactivity just hyperactivity of the GI system, and it can cause constipation, it can cause diarrhea, it can cause cramping pain. Obviously, those three things are going to be the presentations of this condition. It's diagnosed based on how the patient presents. There is something called the Rome-4 criteria. I'm not going to get into that. That's not something you would see on a nursing school exam. I just thought it's really interesting, so I threw it in here to help with the diagnosis. The management of IBS is going to be supported, meaning treat the symptoms. If they have constipation, fluid, diet, exercise, stool softeners, fiber, etc., we're going to teach them to avoid their triggers. So most of these patients, they do have specific triggers, whether it's stress, whether it's activity, whether it's food. We're going to tell them to avoid it. And then if it's constipation, they're usually having increased fiber, fluid, and activity like we already talked about. Next, we move on to IBD. IBD is an autoimmune disease, inflammatory bowel disease. It's one example of an autoimmune condition, and it's broken out into two subcategories, ulcerative colitis and Crohn's disease. These two make up IBD. The pathophysiology, will start with ulcerative colitis, is that it's a chronic inflammatory disease of the colon that starts distally and works its way proximally. The presentation is anorexia, loss of appetite, malaise, not feeling well, cramping. That's obvious. In the left lower quadrant is going to be classic for ulcerative colitis. Bloody diarrhea would be a big indication, a big red flag to me that my patient may have ulcerative colitis. They may have altered nutrition or altered metabolism, as well as a fever when it's acute, because this is a chronic condition. It's going to be lifelong. There's no cure for it. So in the acute setting, they may present with fever. This is diagnosed based on a colonoscopy. The management, we do have a lot of medications that we can use to treat this. Again, all of this is going to be to treat it, to manage it. We cannot cure it. They're going to have this the rest of their life. Sulfasalazine is a medication we use. Steroids we use in the acute setting when they're coming in with a flare-up. Humira, which is a very famous drug, Stelara, Activio. All these are famous drugs. These are monoclonal antibodies. These are injectable medications that take several weeks to months until they actually start to work, but they do work extremely well, massively improve these patients' quality of life. We would also be treating the patients symptomatically, so whatever symptoms they present with in the acute setting, when they're having an acute flare-up, we're going to manage their symptoms. And in severe cases, we may do surgery depending what's going on with the patient. Just a few notes, and these are common test questions. Ulcerative colitis and Crohn's disease are more common in Caucasians than other ethnicities, and more common within Caucasians among the population of Ashkenazi Jews. Next, we have another key nursing point is that these patients are at serious risk of nutritional deficiencies because of the disease process. So we do need to educate them. We need to refer them to nutritional counseling and make sure they're properly educated on how to avoid malabsorption and malnutrition. This disease does go through remissions and exacerbations. So even though the patient's going to have this for the rest of their life, hopefully most of the time they could be in remission, meaning they're relatively asymptomatic. Hopefully usually that would be because it's controlled by medications. And then they may have those exacerbations, these flare-ups. Next, we're going to have IBD, the other one, which is Crohn's disease. Crohn's disease is, again, a chronic inflammatory disease, but not of the colon. It could be anywhere in the GI tract, most commonly the terminal ileum. This presents with a fever, with colicky pain after meal, meaning really severe pain where the patients just can't even get comfortable. They may have bloody or mucousy diarrhea, but that's more associated with ulcerative colitis. They may still have the same anorexia and the same altered nutrition. One of the key words you should definitely look out for on exam is skip lesions. Skip lesions is always associated with Crohn's disease. That's what we see on imaging. And we may have complications of Crohn's disease, such as the disease process causing fistula, strictures, and abscesses to develop along the GI tract. This is diagnosed based on the location where it's at. That's how we diagnose whether this is Crohn's or ulcerative colitis. And then obviously we diagnose it based on the patient's history and based on imaging, so that we see those skip lesions or we see these other complications, we know that it's Crohn's disease. The management is going to be exactly the same as ulcerative colitis. And again, the bullet points at the end, the extra considerations and the common test questions are going to be exactly the same as ulcerative colitis. Next, we have appendicitis. Appendicitis is inflammation of the appendix. And the big issue here is that it can lead to rupture. So appendicitis, the appendix very famously is an organ that we don't fully understand today what exactly its function is within our overall hemodynamic and our overall body purpose, but we don't fully understand that one. How does it present? It presents with periumbilical pain that localizes to the right lower quadrant. So anytime you have right lower quadrant pain, the first thing you should be thinking of is appendicitis, because if that is what it is and it leads to rupture, that could be fatal. McBurney's point is something you may see on some nursing exams. We don't really use that term so much anymore, but you may still see it on your test banks, and that is the right lower quadrant pain, and that's associated with appendicitis. Appendicitis symptoms are also going to be associated with nausea, vomiting, anorexia, fever, and rebound tenderness. Rebound tenderness is when I press down and I let go, and now that hurts. It's diagnosed based on ultrasound or an abdominal CAT scan or CT. The management, these patients are definitely the NPO. We're going to give them plenty of fluids, plenty of pain control. Those three things are identical to pancreatitis. We're going to give them antibiotics if appropriate, and a surgical appendectomy to get rid of the appendix if we're worried about rupture. When for nursing school, definitely look out for any question that says the patient presents with signs and symptoms of appendicitis and has sudden relief, because sudden relief could mean that it actually now ruptured. And even though they have that sudden relief, they're heading to be 10 times worse than they were. Physical examination size, McBurney's point, and all of these, Rovsing, psoas, and obturator are all associated with appendicitis. McBurney's point is classic right lower quadrant pain. Rovsing sign is right lower quadrant pain when we press on the left lower quadrant. That's called referred pain. Psoas sign is pain when you extend out your hip, and so you'd be more comfortable in like the fetal position, but when you extend out the hip, you have psoas sign. Again, that's associated with appendicitis. And obturator sign is pain with internal rotation of the flexed hip. That's a little bit difficult for me to verbally explain to you, but you can probably, you can definitely YouTube that or ChatGPT, then you'll find out right away. Next, let's have diverticulosis and diverticulitis. So diverticulosis are small bulging pouches, which are called diverticula, in the colon wall. Inflammation or infection of these pouches is called diverticulitis. So diverticulosis is if the patient develops these pouches, and if they become inflamed or infected, that becomes diverticulitis. So we're going to talk about these two pathologies together. The presentation is going to be fever, nausea, vomiting, diarrhea, constipation. If you ever see that NVDC, that's me being lazy or the other provider you're looking at, not wanting to spell it all out, but NVDC stands for nausea, vomiting, diarrhea, constipation. Do what I say, not what I do. I just ran out of space on this line. And lower left quadrant abdominal pain, that would be the presentation, the signs and symptoms. Diverticulosis is diagnosed by colonoscopy or by CAT scan, and the management over here is complicated and it's a common test question. These patients should have a high fiber diet to manage their, if they have a history of diverticulosis. However, if they're having an acute episode of diverticulosis, diverticulitis, then we want them to switch to a low fiber diet. Don't get that confused, because I've seen that in a few different test banks. And then also we're going to treat them symptomatically to resolve their symptoms, whatever it is, the nausea, the vomiting, etc. And finally, if they do have an infection, we're going to give them antibiotics for it. We're getting to the end here, so stay with me. We have hemorrhoids. The pathophysiology here is that it is swollen or inflamed veins in the anal canal, and this is due to increased pressure. What causes increased pressure? Increased straining, sitting for a long time, things like that. The presentation, these can be internal, external prolapse. We're not going to get any deeper into it than that. The presentation will be bright red rectal bleeding, rectal pain, rectal itching or discomfort is commonly associated with hemorrhoids. It's diagnosed based on history or physical exam. We could just take a look and see it. The management is based on what caused it. So if the patient is constantly straining, then we try to do things to help relieve their constipation. Again, that fiber fluids activity, also stool softeners if needed. And then there are also some over-the-counter relief medications for hemorrhoids, especially for the itching that's involved with that, such as Preparation H is one of them. We may need surgical intervention if these get really bad or if they're internal, and then that would be a surgical referral. Next, we have celiac disease. The last last about 10 bullet points that I have. I'm going to go through these pretty quick. These are all part of GI, but the rest of this list over here wasn't included in every textbook I reviewed, but since it was in more than one of them, I did throw it in here. So celiac disease, the pathophysiology is autoimmune disorder where the patient's immune system attacks the small intestine whenever gluten is consumed. So it's an autoimmune disease where whenever gluten is consumed, it attacks the patient's small intestine. So it's a disease of the small intestine. The presentation is chronic diarrhea, steatorrhea, which is fat in the stool, abdominal pain, discomfort, and weight loss. This is diagnosed with a specific test, the IgA TTG antibodies blood test, and the management over here. This is on you. This is on nutrition. This is on counseling. This is on patient education to get them to a gluten-free diet. Next, we have C. diff. C. diff again, not very commonly or not extensively covered in GI, but we'll talk about it real quick. This is also an infectious disease topic. C. diff is where a patient has Clostridium difficile, which is a bacterial pathogen. This is chronic in patients, but when a patient, or I'm sorry, this is a bacteria that can be in a patient and it can be not a big issue, but when a patient has their normal gut flora, meaning the normal environment of their stomach disrupted, usually through a powerful antibiotic, the patient may develop C. diff. How do we diagnose C. diff? You should know this for test purposes. Watery diarrhea, which is more than 3 loose stools within 24 hours, plus abdominal pain, nausea, and fever. This is diagnosed based on stool testing, and if the patient has this, excuse me, they are going to be treated pharmacologically with vancomycin or some other antibiotic. I've seen this as a very common test question. They should not take loperamide. Loperamide is an anti-diarrhea agent, but all that's going to do is keep this. It's going to stop the patient from having diarrhea, but it's going to keep this infection inside of them. We want them to basically poop out the infection. So we want that to happen. So we're not going to give them an anti-diarrhea agent. And very importantly, especially for nursing school exams, use contact precautions. Next, we have the SBO or LBO. That's a small bowel obstruction or a large bowel obstruction. The pathophysiology is exactly what it sounds like. The presentation is going to be abdominal pain. They may have abdominal distension. They may have early satiety, which means that they feel full very soon after eating just a little bit. They may have a lack of bowel movement, a lack of bowel sounds. They may have a lot of different signs and symptoms that are very specifically associated with SBO and LBO that are listed here. Definitely know this list. I do want to mention one thing called a rigid abdomen. If you ever see that, especially on an exam or certainly in real life, that's a true medical emergency. That's where the patient has a board-like abdomen, that it's very hard, it's very solid when you press on it. We're not talking where they're flexing their ab muscles. This is just where you're palpating, and it should be soft like a normal abdomen, but this becomes rigid. That could be a problem. It's associated with SBO and LBO. It's also associated with bleeding into the abdomen. This is diagnosed with an abdominal x-ray, or we would certainly catch it with a CT as well. This patient must be NPO. We may put in an NG tube in order to get the any excess food or something that's backed up by the obstruction to get it out of the GI system. If it's an LBO, we may disimpact them to be able to clear that out, and this may get referred to surgery. Be careful with SBO or LBO because the patient can cause a perforation. If it's blocked and now there's a backup, when there's a backup, there's high pressure. If there's high pressure, it can rupture, it can perforate, and now all of a sudden the patient's going to end up quite possibly in sepsis. So this is definitely something you're going to look out for. You may hear a term ileus in either nursing school or nursing school exam. And ileus is a temporary loss of normal peristalsis. It's basically paralysis of a section of the GI system. That's what an ileus is. It's where a portion of the GI system becomes paralyzed. Very common not very common, but it's something that we look out for post-surgery. Next, we have ectopic pregnancy. Again, this is getting pretty out there with what would be covered in a GI lecture, but I want to be all-inclusive. The ectopic pregnancy is where an egg implants inside the fallopian tube or somewhere else other than inside the uterus. In this case, as the fetus grows, it's going to keep growing. Eventually, it will explode the fallopian tube, and the patient can end up in septic shock and die. In all cases, as of early 2025, when this is being recorded, we cannot fix that. We've tried a number of times to get an ectopic pregnancy successfully implanted back into the uterus for the baby to survive. That hasn't successfully happened. So as of today, the standard of care in all cases is that we abort those pregnancies, usually with a medication such as methotrexate. This is a medical emergency because if it's left undiagnosed, as the fetus grows, it will rupture the fallopian tube and the patient can end up in sepsis and die. Next, we have gastroenteritis. Gastroenteritis is the number one diagnosis of patients that come into the ER with abdominal pain or nausea or vomiting. very interesting. It's the number one diagnosis. It's basically a stomach bug or the stomach flu, lots of different lingo out there for it. But it's inflammation of the stomach or intestines due to an infection. Could be viral, bacterial, could be E. coli, salmonella, norovirus, rotavirus, any of those things. The presentation will be an acute onset of nausea, vomiting, watery diarrhea, abdominal pain, fever, possible dehydration. This is diagnosed based on the story, and we may need to rule out one or two other things before we conclusively say that it's gastroenteritis, but that's usually where we end up. Symptomatic treatment, as we said, we treat the symptoms that the patient's having. Lactose intolerance, again, I'm getting even further down the list of what would be covered in a standard GI course, but let's just wrap it up. We've got a few minutes left. Lactose intolerance is going to be a digestive disorder caused by lactase enzyme deficiency. If you don't have lactase, you can't tolerate lactose. If you can't properly tolerate lactose, you're going to get produce gas, bloating, diarrhea, and abdominal pain. The classic symptom here is going to be flatulence. The diagnosis is made by a lactose tolerance test, and the treatment involves educating the patient to stay away from lactose products. There is also where the patient can eat lactose products and just take a lactase supplement. That, remember that what they're missing, that lactase enzyme deficiency, they could take lactase and then eat lactose. Gastroparesis, in case you hear that term, it's a condition where the stomach takes too long to empty its contents into the small intestine. That can lead to nausea, vomiting, abdominal pain, and that early satiety where the patient is, hopefully I'm pronounced that correctly, it's where the patient eats and after very little food, they're already feeling full because, again, the stomach's not emptying like it's supposed to. Next, we have peritonitis. This is inflammation of the peritoneal cavity. The peritoneal cavity is what contains most of our GI system. This can present with severe abdominal pain and other symptoms and signs that are listed here. These patients do need to be NPO. They are going to give an IV fluid. They may be given antibiotics if it's infectious. They're definitely going to get some pain control medication. They may get an NG tube if we want to keep the stomach empty, if there's something in there, and they may need surgery depending on any complications that develop. Real quick, a few things left. Mallory-Weiss here. This is not really part of GI, but this may come up in a GI lecture. If you do hear this term, this is an esophageal mucosal tear. This is where the esophagus, the tissue of the esophagus, that's a tear in it, and that would be most commonly caused by very forceful vomiting. Dumping syndrome, we see this a lot of times after surgery, not a lot of times, but sometimes after surgery. And definitely if you see this on a test, they're probably looking for some after surgery question. And that's going to be rapid gastric emptying where the stomach quickly empties out after gastric surgery instead of it starting the appropriate amount of time where the stomach keeps the stuff inside the stomach, the chocolate cake or whatever we ate, and breaks it down before sending it down into the duodenum, into the small intestine. A volvulus is the twisting of the bowels. This can cause ischemia, pain, vomiting, and distension. I'm not going to go any deeper than this, into this. Oh my gosh, I can't talk anymore, but I'm not going to get further into that. But if you do see the term volvulus, it's a twisting of the bowel, and it's generally going to be referred for surgery or something like that. Aspiration risk or dysphagia. These are the last two terms I have. If you do hear these terms, this is where patients have difficulty swallowing. That's what dysphagia is. And if the patient is at aspiration risk, then we're talking aspiration pneumonia. And who are we talking about? We're talking about patients that have a stroke or that have other neurodegenerative diseases where they're unable to control that swallowing. I said we talked about this earlier. And this is talking where the patient has failed a swallow study, meaning that they got a test done. Very interestingly, this test is done by a speech therapist. But in these cases, these patients are going to be NPO for nursing exam questions. They might get thickened liquids because that's more easy for them to control and get it down the esophagus instead of it ending up in the lungs. These patients should be upright during meals, again, to facilitate the patient not getting the food down the wrong pipe, and they're going to get a speech therapy consult to be able to resolve this. Hopefully you enjoyed this lecture and learned a lot. Here's our references. If you have any questions, please reach out and subscribe to our channel. Have a great day.